Welcome to The Explainer. Today, we are diving into one of the most intense challenges in all of medicine, managing childbirth for a mother with Eisenmenger syndrome. This is a condition that, believe me, turns pregnancy into a life-or-death tightrope walk. So let's just start with a number that puts everything into perspective. For a woman with Eisenmenger syndrome, getting pregnant carries a maternal mortality rate of 30 to 50%. I mean, that's just a staggering risk, so profound that for a long time, pregnancy was considered an absolute contraindication. So in this explainer, we're going to unpack exactly why this condition is so dangerous. We'll break down the central dilemma for anesthesiologists, and then we'll explore the incredible modern strategies that are actually making survival possible. Okay, so first things first. What in the world is Eisenmenger syndrome, and why does it turn something as natural as pregnancy into such a high-risk event? Well, it all starts with a defect someone is born with, usually a hole between the heart's chambers. Over many years, this defect just floods the lungs with way too much blood, causing all this irreversible damage and making the pressure in the lungs' arteries dangerously high. Eventually, that pressure gets so extreme that the whole system flips. The flow of blood actually reverses, and now you've got oxygen-poor blood getting pumped straight out to the body. So, here's the key thing you've got to understand. People with Eisenmengers are living on a knife's edge in this incredibly fragile hemodynamic balance. The resistance to blood flow in their lungs, that's the PVR, is basically equal to the resistance in the rest of their body, the SVR. Any little thing that upsets this balance, well, it can be absolutely catastrophic. And pregnancy doesn't cause a little change. Nope, it causes a massive one. Your blood volume goes way up, and your body's overall vascular resistance, the SVR, naturally drops to accommodate the pregnancy. This doesn't just nudge that fragile balance, it violently throws it off a cliff. The shunt gets way worse, and the result is severe, life-threatening oxygen deprivation. Okay, so imagine a mother needs a C-section. This puts the anesthesiologist in a truly terrifying spot, facing what seems like a total no-win choice between the two main anesthesia options. And this is the classic rock-and-a-hard-place scenario. If you go with general anesthesia, you risk spiking that lung resistance, the PVR, especially when you're putting the breathing tube in. But if you choose regional anesthesia, like a spinal or an epidural, you risk tanking the body's resistance, the SVR. Either way, you're making that deadly shunt worse. It's an incredible dilemma. So what do you do? I mean, really, with both options carrying these huge, almost opposite risks, which door do you pick? How do you even begin to make a call when it seems like either choice could lead to disaster?
Well, this leads us to the fundamental insight, the game-changing principle that has totally revolutionized how these cases are managed.
And here it is. The big breakthrough was realizing that the choice of anesthetic technique is not the most important decision, not even close. The one and only thing that matters, the absolute core mission, is to maintain that hemodynamic stability at all costs. It's about preventing any big shift in that fragile balance, no matter what anesthetic you're using.
But, to keep things that stable, you can't just guess. You can't fly blind. Modern medical teams now rely on this whole suite of advanced monitors to get a real-time, second-by-second picture of what's happening inside the body. This allows for a strategy we call goal-directed therapy.
And this is the high-tech toolkit we're talking about. Forget a blood pressure cuff check every 5 minutes. An arterial line gives you beat-by-beat blood pressure. A central line gives you a window into the right side of the heart. And these amazing pulse contour analysis systems give you continuous data on things like cardiac output and SVR. It basically turns the operating room into a high-tech command center, letting the team react instantly and with incredible precision. So you've got all this real-time data streaming in. What does the actual game plan look like? How do you use all that information to keep the patient safe through the procedure? The strategy has to be both proactive and aggressive. The team's job is to get ahead of any problem. They attack anything that could make that lung resistance go up. Things like low oxygen or acidosis, before it's even an issue. At the very same time, they're using medications to actively support the body's resistance, the SVR, to make sure it doesn't drop. It is a constant, vigilant, high-wire balancing act from start to finish. And they do this with a really sophisticated set of drugs. It's like fighting a battle on two fronts. On one side, they use pulmonary vasodilators like sildenafil, often at a dose around 50 milligrams every 8 hours, to specifically open up the blood vessels in the lungs.
But on the other side, they're using vasopressors like norepinephrine to keep the body's vessels tight and prop up that SVR. And if the heart muscle itself starts to get tired, they can add another drug, an inotrope, to help it pump stronger.
And the proof is in the results. Case studies show this approach works with all different kinds of anesthesia. One team used general, another used spinal, but they did it in a cardiac OR with a heart-lung bypass machine ready to go just in case. A third team used an epidural, guided by that advanced monitoring. You see, the technique was different every time, but the core principle was always exactly the same: meticulous, data-driven management to keep everything stable.
And this is so important to remember. This kind of success is never about one person. As one of the case reports puts it perfectly, it requires a multidisciplinary approach. A whole team of experts, cardiologists, surgeons, obstetricians, anesthesiologists, all working together in perfect sync. When you step back and look at it, the successful management of Eisenmengers in pregnancy is just an incredible testament to how far medicine has come. It shows what's possible when you combine a deep understanding of the problem with advanced technology and, maybe most importantly, collaborative teamwork. You can turn what was once a near-certain tragedy into a story of survival. And it really makes you wonder, doesn't it? What other conditions that seem impossible today will become manageable tomorrow?